نعم أستاذ. Assalamu alaikum. My seminar today is about the biliary system. First, starting with the gallbladder. The gallbladder is a pear-shaped sac. It's attached to the extrahepatic bile ducts by the means of the cystic duct. Okay, this is the gallbladder, and it's attached to the extrahepatic bile ducts by the cystic duct. It's about 10 centimeter in length and 3 centimeter width, and the wall thickness is up to 3 millimeter. It has three parts: fundus, body, and the neck. The neck has infundibulum, and sometimes there is a Hartmann pouch. The Hartmann pouch is a pouch on the ventral surface of the gallbladder, just proximal to the neck. This is seen usually when the gallbladder is dilated, and probably it's not a part of the normal anatomy. This is the Hartmann's pouch. Okay, the clinical significance of this pouch, sometimes a gallstone may get impacted in the Hartmann's pouch, causing compression of the cystic duct and leading to Mercedes syndrome. Regarding the mucosal lining of the gallbladder, it's usually smooth, except at the neck and the cystic duct, where it will form folds with spiral arrangements. These are the folds with spiral arrangements that regulating the bile flow, and they are called bulb of Hester. They are very echogenic and sometimes may be mistaken for gallstones by ultrasound. The anatomical relationships of the gallbladder, anteriorly and superiorly, it is related to the gallbladder bed of the liver and anterior abdominal wall, the fundus part of the gallbladder. The fundus part lies at the junction of the lateral rectus muscle, lateral border of rectus abdominis, and the tip of the ninth costal cartilage. While posteriorly and inferiorly, it is related to the neck, related to the lesser omentum, the hepatoduodenal ligament, and the body related to the duodenum, and the fundus is related to the transverse colon. The gallbladder shapes, normally the typical pear-shaped gallbladder, this is the typical pear-shaped gallbladder, sometimes may be elongated or S-shaped with multiple kinks or folds, and sometimes the fundus may fold it over itself, resembling a Phrygian cup. The variants of the gallbladder, they can be the morphology in the number or in position. This is the normal morphology of the gallbladder. Regarding morphology, we have septated gallbladder. It can be a single septum or multiple septations of the gallbladder. This is also a multiseptated gallbladder. The Phrygian cup, this is the Phrygian cup, when the fundus folds back about itself, forming the Phrygian cup. The clinical significance of this variant and multiple variants is that it causes the stasis of bile, leading to the formation of gallstones. The diverticuli, commonly we can see the diverticuli in the fundus of the gallbladder. This is a CT scan sagittal section showing the diverticuli in the body of the gallbladder. Variation in position of the gallbladder. Sometimes it can be suprahepatic, as we can see here, just posterior to the anterior abdominal wall. And this is also an axial CT scan showing the suprahepatic gallbladder. Retrohepatic gallbladder. This is an ultrasound examination showing this is the liver and this is the right kidney, and the gallbladder is posterior between the liver and the right kidney. Axial CT scan also showing the posterior location of the gallbladder. The intrahepatic gallbladder, which can be normal in fetus, not the neonate, up to 2 months. And we can see here the gallbladder completely surrounded by the liver. Intrahepatic gallbladder, here we can see intrahepatic gallbladder completely filled with stones. We have left-sided gallbladder. As you can see, this is an axial CT scan showing the left-sided or the gallbladder under the left lobe of the liver. This is a left-sided gallbladder. This is also a left-sided gallbladder filled with stones. And this is a case of situs inversus. As we can see, the liver is on the left side and the spleen on the right side, and the gallbladder here is left-sided. Sometimes it can be herniated through the epiploic foramen. Gallbladder duplication, although it's rare and commonly it shares a duct, could be septated gallbladder or fundal duplication, the body or Y-shape, complete duplication, or bilateral gallbladder. This is a gallbladder duplication. This is an axial CT scan showing complete duplication of the gallbladder. The arterial blood supply of the gallbladder. The main arterial blood supply comes from the cystic artery, which is a branch of the right hepatic artery, and some direct branches, they come from the liver of the gallbladder bed. The venous drainage, the main venous drainage is through small veins go to the liver from the gallbladder bed, and sometimes a cystic vein may form and it will drain into the portal vein. The lymphatic drainage of the gallbladder, there are three pathways for lymphatic drainage. The main pathway is the retropancreatic pathway. It will go to the retropancreatic lymph nodes. And the other pathway is the celiac lymph nodes along the hepatoduodenal ligament to the celiac group of lymph nodes, or to the mesenteric pathway anterior to the portal vein going to the superior mesenteric group of lymph nodes. Okay, it's either to the celiac group of lymph nodes or pancreatic, which is the main pathway, or superior mesenteric lymph nodes. Starting with the bile ducts, the intrahepatic bile ducts, they follow the same distribution as the hepatic artery and the portal veins. The bile ducts from the segments, they usually unite to forming the right and left hepatic ducts. As we can see, this is the left hepatic duct formed by the fusion of the hepatic ducts of segment 2, 3, and 4 of the left lobe of the liver. While the right hepatic duct is formed from the fusion of the right anterior duct and the right posterior duct. The right anterior duct is draining the anterior segments of the right lobe, which is segment 5 inferiorly and segment 8 superiorly. While the right posterior duct, it drains the posterior segments of the right lobe, which is segment 6 inferiorly and segment 7 superiorly. The right hepatic duct and the left hepatic duct, they will fuse to forming the common hepatic duct. Okay, again, intrahepatic bile ducts. The right hepatic has two major tributaries. A right anterior duct draining the anterior segments of the right lobe, which is segment 5 and segment 8, and the right posterior duct draining the posterior segments of the right lobe, which is segment 7 and segment 6. A right anterior duct usually fuses with the right posterior duct on its medial aspect, forming the right hepatic duct. A left hepatic duct formed by the duct draining the segments of the left lobe, segment 2, 3, and 4. A bile duct, which drains the caudate lobe, usually either joins the right hepatic duct or the left hepatic duct. Okay, the diameter of the right and left hepatic duct usually up to 3 millimeters. Okay, this is again the schematic representation showing the intrahepatic bile duct. This is the right anterior duct and the right posterior duct, okay, forming the right hepatic, and this is the left hepatic duct, and the caudate lobe either joining the right or the left hepatic ducts. The common hepatic duct. The common hepatic duct formed by the union of the right and left hepatic duct outside the liver parenchyma at the porta hepatis, and usually lying anterior to the portal vein in the free edge of the lesser omentum in the hepatoduodenal ligament. And hepatic artery usually on its left side. The mean diameter is about 7 millimeters, and it is joined by the cystic duct after a variable distance about 3.5 cm. The cystic duct, it connects the gallbladder neck. This is the cystic duct, connecting the gallbladder neck to the common hepatic duct, forming the common bile duct. Okay, it's about 3.5 centimeter long, 2 to 3 millimeter in diameter, and lies anterior to the cystic artery. This is an MRCP showing the cystic duct. Okay, this is the gallbladder, and this is the common hepatic duct. The joining of cystic duct and common hepatic duct, it will form the common bile duct. The common bile duct, as we said, is formed by the confluence of the cystic duct and the common hepatic duct. It's about 8 centimeter long, less than 6 millimeter in diameter. The diameter can vary with age, with increasing age, and the upper limit is 1/10 the age of the subject in millimeter. Okay, so at the age of 80s, it will be 8 millimeters considered normal. And after cholecystectomy, up to 1 centimeter is considered normal. The common bile duct, it has 3 parts: supraduodenal part, retroduodenal part, and the retropancreatic part. The supraduodenal, this is lie in the free edge of the lesser omentum, and the hepatic artery lie on its left side with portal vein posteriorly. The retroduodenal part, this is commonly seen by ultrasound, the supraduodenal part. Retroduodenal part is behind the first part of the duodenum and runs with the gastroduodenal artery. And the third part, or the pancreatic part, passes behind the pancreas in a tunnel toward the second part of the duodenum. This is why the CA head of pancreas here, it will compresses the common bile duct, causing an early detection of this cancer by causing obstructive jaundice. The common bile duct, okay, the common bile duct, it will unite with the main pancreatic duct, and they will open at the common dilated ampulla of water in the second part of the duodenum through the major duodenal papillae. The minor duodenal papillae is for the drainage of the accessory pancreatic duct. This ampulla is surrounded by a circular layer of involuntary muscles known as the sphincter of Oddi. It will form a bulge inside the duodenum, which can be easily identified by endoscopy during ERCP for cannulation of the common bile duct. Relationships of the hepatic ducts and hepatic artery and the porta hepatis. Sometimes we have variations. In 2/3 of cases, the bile duct, it lies anterior to the right hepatic artery, as we can see here clearly. In 1/4 of cases, the right hepatic duct, it will passes the hepatic duct or the bile duct, it rises behind the right hepatic artery. In 12% of cases, we have aberrant right hepatic artery, which arises from the superior mesenteric artery, and it will passes behind the bile duct. The variation of the biliary tree, it's more commonly occur in the intrahepatic bile ducts and occur in 40% of cases. Okay, this is the normal anatomy. This is the usual left hepatic duct. We have the right anterior duct joined by the right posterior duct to form the right hepatic, and they will form the common hepatic duct in 65% of cases. Sometimes the right posterior duct, it will join the left hepatic duct, and this is the most common variant, 20% of cases. Sometimes the right anterior duct, right posterior duct, and the left hepatic duct, they will join together to form the common hepatic duct in 10% of cases, while in some cases, the right posterior duct, it may join directly the common hepatic duct in 5% of cases. The variation in the bile ducts, either we have double hepatic ducts, the right and left hepatic ducts sometimes may fail to unite. Either we have low union, as can be seen here, or the right and left hepatic duct, they fail to unite and they join the cystic duct to form the common bile duct. Accessory hepatic ducts, these usually arising from the right lobe of the liver. So this accessory hepatic duct, either it will join the common hepatic duct, or it will join the cystic duct, or it will join the common bile duct, sometimes joining directly the gallbladder, or sometimes we have two accessory hepatic ducts. The variations which can be seen in the cystic duct, either low union with the hepatic duct, or adherent to the common hepatic duct fused together, or high union with the common hepatic duct. Either cystic duct could be very short or absent. We have an anterior spiral joining the common hepatic duct on its left side, or posterior spiral, it will join the hepatic duct also on its left side. The variation which can be seen in the common channel, the mean length of the normal channel, which is formed by the common hepatic duct and the main pancreatic duct, it's normally 4 to 5 mm. Sometimes we have very short channel or no common channel, which the common bile duct and the pancreatic duct, they open separately in the second part of the duodenum. Or we have very long channel, about 15 millimeter, they will open also with ampulla of water, the second part of the duodenum. Starting with the radiological imaging of the biliary tree. The imaging modality, we have the plain film of the abdomen, ultrasound examination of the biliary tree, contrast examinations, MRCP, CT of biliary tree, and ERCP, scintigraphy of the biliary tree using the technetium-99 high-def scan. Plain film of the abdomen, the normal gallbladder and biliary system are not visualized by plain abdominal X-ray. Only calcification or gas can be seen in the biliary tree. As we can see here, these are gallstones. These are gallstones within the gallbladder. Here we can see pneumobilia, okay, which is a central gas can be seen inside the biliary tree. This is usually pathological, except in certain conditions can be considered normal. In elderly people, when ampullary tone is low, after sphincterotomy during ERCP, or after surgical anastomosis of the bile duct to the small bowel in cholecystectomy. And this is usually done, for example, in Whipple bypass surgery for CA head of pancreas, in which we do anastomosis of the common bile duct with the duodenum. Okay, here we have calcification in the wall of the gallbladder. This is called porcine gallbladder, and it is a precancerous lesion. Here we have a gallstone and gas in the wall of the gallbladder. This is a case of emphysematous cholecystitis. Okay, we need to differentiate between pneumobilia and portal venous gas. Pneumobilia is CPD, so remember it is central regarding the pneumobilia, while portal venous gas is peripheral. Okay, why? Because the flow of the bile, it will pushes the gas toward the hilum, and that's why it's central regarding pneumobilia, while the portal venous gas is usually peripheral because the portal vein, it will pushes the gas away from the hilum. This is the appearance of the pneumobilia by axial CT scan. We can see it is central, while portal venous gas can be seen it is reaching the periphery of the liver. Ultrasound examination. The size of the gallbladder, the ultrasound will show us the gallbladder, the extrahepatic biliary tree, and intrahepatic in the high resolution scanners. The size of the gallbladder, depending on the feeding or the fasting state, the degree of distension also depends on the wall thickness, depend on the degree of distension. Normal wall thickness in a fully distended gallbladder during fasting is up to 3 millimeters thick and seen as a thin echogenic line. Okay, the intrahepatic bile ducts can be seen in high resolution scanners and is usually less than 3 millimeter or less than 40% of the caliber of the adjacent portal venous branch. Here we can see an obstructing lesion causing localized dilatation of the intrahepatic bile duct, which has a serpentine wavy appearance. Also, we call it the double barrel sign. Okay, this is showing the left hepatic duct and the right hepatic duct. This is the right anterior and the right posterior. These are segment 2, 3, 4 forming the left hepatic duct. Ultrasound examination regarding the upper limit of the common hepatic ducts, variable with age. The mean diameter is 3 millimeter at age of 20. Up to 6 millimeter is considered normal. The upper limit of CPD is 1/10 the age of subject in millim, as we said earlier. So it's 8 millim for the age of 80 is considered normal in older subjects. Up to 1 centimeter is normal post-cholecystectomy. This is an ultrasound examination. This is a normal CPD. This ultrasound shows a dilated common bile duct. This is the hepatic artery, the common bile duct, and this is the portal vein posteriorly. Okay, this is showing a stone inside the dilated common bile duct with this acoustic shadow. Contrast examinations, we have the IV intravenous cholangiography, oral cholecystography, and these are largely replaced by the MRCP and by ultrasound. The intraoperative cholangiography and T-tube cholangiography, largely replaced by MRCP, percutaneous transhepatic cholangiography, and the endoscopic retrograde cholangiopancreaticography. The IV cholangiography and oral cholecystography, we give the patient a cholangiographic contrast agent, either oral or IV, and after a certain time period, we do a plain abdominal X-ray to visualize the biliary tree. Oblique view are usually required to projecting the biliary tree away from the spine. And nowadays, they are no longer used. They are largely replaced by ultrasound as the first imaging modality for the biliary tree. The percutaneous transhepatic cholangiography. Okay, this technique is now used, most commonly punctured ducts percutaneously are the ducts of the inferior segments of the liver because they are the most accessible. That's to say they are segment 5 or 6 in the right lobe and segment 3 of the left lobe. They use Chiba needle. This needle is resembles the CSF needle but slightly longer and can be used to reach the biliary tree and injecting the contrast agent. The percutaneous intrahepatic cholangiography can be either diagnostic or therapeutic. For example, for biliary drainage procedure, to placing percutaneous biliary stent, to dilating a postoperative structure, rarely used for diagnostic purposes only. Regarding an intraoperative cholangiography, this is usually done during laparotomy or laparoscopy by the surgeon, in which cannulation of the cystic duct is done and injection of contrast to see if there is any gallstone. And we can see here gallstone seen in the cystic duct. This is now largely replaced by MRCP pre-operatively. The T-tube cholangiography, this is done usually following cholecystectomy post-operatively. The surgeon inserts the T-tube during the surgery. This is the short limb in the extrahepatic ducts, and this is the long limb percutaneously. And the injection of contrast is done to exclude any retained stone inside the biliary tree. Okay, then this is no longer used nowadays because replaced by MRCP. The ERCP, it is also replaced by MRCP as the first line investigation in the intra and extrahepatic bile ducts. And it is still largely used for interventional procedures for therapeutic purposes. Okay, as we can see here, this is the left hepatic duct. This is the right hepatic duct. Okay, form the common hepatic joined by the cystic to form the common bile duct. Okay, and this is the endoscope. We do cannulation of the ampulla of water and inject the contrast to visualize the biliary tree. And we can also do therapeutic procedures. The MRCP is an excellent image of the biliary tree. Replace the RCP as the first line investigation because it is non-invasive technique and required no contrast. And using the heavily T2 weighted fat suppression sequences, the static fluid in the bile duct is hyper intense and the background signal is suppressed. So we can see the biliary tree clearly without need for any contrast. As we can see, this is the intrahepatic bile duct. This is the common hepatic joined by the cystic duct. This is the common bile duct joined by the main pancreatic duct and opening the second part of the duodenum. Again, this is the right hepatic duct, left hepatic duct, the common bile duct, pancreatic duct, and this is the gallbladder. CT of the biliary tree. This is a CT scan, axial CT scan with contrast. We see that the kidney took the contrast, and we can see the liver enhancement. And the biliary tree will be seen as a low-density linear structures running anterior to the portal venous system because it does not take the contrast. This is the gallbladder. We know the position of the gallbladder is sometimes variable, but neck is usually constant at the porta hepatis, defining the quadrate lobe anterior-medially. Body and fundus, they lie transversely closely applied to the visceral surface of the liver and may hang inferiorly. Sometimes the fundus can reach as inferiorly far as the pelvis. CBD is normally seen anterior to the portal vein in the porta hepatis, but at a lower CT level, the CBD is seen in a tunnel posterior to the head of the pancreas, and the body is seen anterior to the duodenum. The CT cholangiography, this is different from CT with contrast. This is excellent technique to show the normal anatomy of the intrahepatic ducts. We give an IV contrast cholangiographic agent like sodium iotroxate. This is given, and after 30 minutes, we can do the CT scan to visualize the biliary tree. This is also largely replaced by the MRCP. Scintigraphy of the biliary tree using the technetium-99 hide scan. We give an IV radiopharmaceutical labeled to the technetium, and this will accumulate in the liver parenchyma and excreted by the biliary system. It will outline the intra and extrahepatic bile ducts, the gallbladder, and the cystic duct, and it's mainly used for functional assessment. As we can see here, it shows the intrahepatic duct, the gallbladder, the common bile duct, and this is the early phase and late phase. This is mainly used for the diagnosis of biliary atresia in the neonate, failure of excretion of the radiotracer, and after the late phase of the study, it indicates the presence of biliary atresia. Okay, this is the radioactive tracer inserted IV, imaged by a gamma camera using this hide scan labeled to technetium to visualize the biliary tree and assess the function of the functional excretion of the biliary tree. Also, in acute cholecystitis can be used. This is the normal hide scan. We can see the tracer seen in the common bile duct, the gallbladder, and the small bowel. While here in acute cholecystitis, there is no radiotracer seen in the gallbladder. It is seen in the CBD and in the small bowel. Any questions?
عشت ايدك دكتور زيد يوسف. اكو احد عنده سؤال على البلياري والجول بلادر قبل ما نروح على الكويز؟ ماكو. اذا نروح على الكويز. نبدي بدكتور عمر فهمي.
نعم أستاذ. نمبر 1 هو confluence of cystic and bile duct.
confluence of cystic. اوكي. الفحص MRCP طبعا هذا.
MRCP نعم أستاذ.
بس هو MRCP
شلون
لو
بعد؟
MRI هذا؟
نعم أستاذ.
MRI لو MRCP؟
MRCP.
هذا. شنو الفرق بين الMRCP والMRI؟
استاذ هو MRI يعني titulated image بس بدون subtraction للإيمج، بدون suppression للأذر organs.
هسه هذه مو سبريزد.
نعم
صحيح.
هذا MRI والكونتراست.
هذا MRI. لا هو عادة هذا MRI T2 ما ينطون كونتراست بالMRI، يعني إذا MRCP والهاي ما ينطون كونتراست، بس هو ما دام ماكو سبتراكشن تعرف احنا الMRCP يطلع بس البلياري تري. هنا الليفر ده تشوفه الديافرام السكين
نعم
البول.
هي الصورة نصا من ريان أنا جاي أستاذ.
لا ماكو مشكلة، أنا ما اختلفت وياك. نعم. بس هي مو MRCP، هذه MRI. الMRCP هذاك عادة فوليومتريك ويحددها على الاريا مالت الهاي، وشكو باك جراوند ستراكشرز المفروض يسوي لها سبريشن، بس هنا ما مسوي سبريشن. مو مهم. نعم. اوكي بس هي مو MRCP. الMRCP اللي طلعته انت دكتور زيد.
نعم.
نروح على عبد الكريم ناهل. نمبر 2.
استاذ نمبر 2 رايت هيباتيك دكت.
رايت هيباتيك دكت. شيماء علاء مكي. نمبر 3.
This is the left hepatic duct.
اوكي. نمبر 4 نروح على علي حسين مصطفى.
نعم استاذ. نمبر 4 هو البنكرياتيك دكت.
This is the pancreatic. محمد مهدي. نمبر 5.
الفايف هي الستومك.
الستومك. اكسلنت. لارا سألناها. لارا.
نعم أستاذ. نمبر 6 gallbladder.
This is the gallbladder. اوكي. نروح على زهراء صباح. نمبر 7.
نعم أستاذ. portal vein.
أشر عليها. نمبر 7 هذه بورتال. اوكي. حيدر كريم. نمبر 8.
نعم استاذ. نمبر 8 رايت ليفر لوب.
رايت ليفر لوب. سالي. نمبر 9.
نعم أستاذ. left liver loop.
ليفت ليفر لوب. واخير وحده نمبر 10 سما.
نعم
اوكي.
duodenum.
اوكي. عندك بعد زيد؟
نعم سألته هواي هي حقيقة.
استاذ محمد.
استاذ اكو اناتوميكال بهاي الصورة.
اكو شنو؟
the anatomical variant in this image.
anatomical variant. من يقول لنا دكتورة سما؟
نعم.
الفاريانت اللي موجودة بهاي الايمج. يعني الصوت راح مدى اسمع كل شيء. تسمعوني؟
نعم.
نعم استاذ. يمهن ضعيف.
نعم استاذ.
رنين.
نعم أستاذ.
What variation in this image?
Radial lobe, inferior extension of the right lobe.
Excellent. اوكي. استاذ محمد كمل.
نعم عين صلع. عقيل وين الصورة؟
نعم أستاذ.
يلا خير. عقيل نمبر 8. شوف هسه هاي ام ار سي بي، قبل شويه ما كانت ام ار سي بي.
نعم تمام. اي جول بلادر استاذ.
اي جول بلادر. دعاء علاء بي.
نعم. هذه اللي كمان بايل داكت.
كمان بايل داكت. زين. دعاء سعد. سي.
نعم أستاذ. proximal right ureter.
زين. كازان دي.
نعم أستاذ. left hepatic duct.
left hepatic duct. نور بابا اي.
نعم أستاذ. pancreatic duct.
pancreatic duct.
عشت ايدك.
زين منو بعد؟ خنساء.
نعم أستاذ.
letter A.
portal vein.
portal. زين. نور محمد جواد بي.
نعم أستاذ. hepatic artery.
نور قاطع سي.
نعم أستاذ. سي بي دي.
سي بي دي. رشا داخل.
نعم أستاذ. دي جول بلادر.
جول بلادر. رقية.
نعم أستاذ. هيباتيك فين.
طلع لهم الإجابة زيد كلي تدي يساعدهم.
يعطيهم نقل.
لا سامحك هي هاي الصيدة.
يلا استاذ رعد كمل انت استاذ رعد.
عيني احنا هسه تقريبا هم كلهم يعني فعلناهم، بس مع ذلك احنا نكمل نشوف منو بالله. حيدر كريم.
نعم أستاذ. رقم 1 الاندوسكوب.
شو نطلع الإجابة قبل ما نسألهم.
اي ما
انت صح مطيهم نقل، انت مطيهم نقل اللي قدامه وبالكويز، يعني مرتين مطيهم نقل.
يساعدهم جماعته. يلا رقية.
نعم أستاذ. نمبر 2 بنكرياتيك داكت.
بنكرياتيك داكت. صفا شامل.
أستاذ. نمبر 3 كمان هيباتيك داكت.
كمان هيباتيك. رشا داخل.
أستاذ. نمبر 4 cystic duct.
cystic duct. شيماء علاء مكي.
نعم أستاذ. نمبر 5 left hepatic duct.
left hepatic. بعد عندنا عقيل.
نعم أستاذ. 6 right hepatic duct.
right hepatic. عمر فهمي مرة أخرى هم نسأله.
نعم أستاذ. جول بلادر 7.
7 جول بلادر. اكو بعد لو خلصن؟
بعد 8.
هواية. زين. نروح علي حسين مصطفى.
نعم أستاذ. نمبر 8 غاز إن ذا ستومك.
غاز إن ذا ستومك. بقن 9 و10. زهراء صباح.
نعم. غاز إن ذا دودينام 9 و10 هو الهيميدايفرام.
الرايت هيميدايفرام.
العفو دكتور، بس الفاريشن مال يعني